Kovich-Bordnick. I'm the CEO of the eHealth Initiative and Foundation. I'm so delighted to welcome you to our webinar this afternoon, Connecting Communities, Health Information Exchanges, and Social Determinants of Health. We have a great program for you this afternoon with a really impressive lineup of speakers. So I'm actually going to get right to it. We've got a few housekeeping items. So we have quite a large group that's going to be joining us this afternoon. So I'm going to get through some of these housekeeping items as we wait for the rest of the folks to log on here. As I mentioned before, I'm Jennifer Kovich-Bordnick, CEO of eHealth Initiative. We've got a great show today. We have 3 presentations. We're going to hear from Lizzy Feliciano, who is the Vice President of Marketing at LexisNexis Healthcare. We're going to also hear from Jordan Luke, the Director of Program Alignment and Partner Engagement Group at CMS, the Office of Minority Health, and then we'll hear from Dr. Chris Hobson, who is the Chief Medical Officer at Orion Health. And we're going to wrap up the day with Q&A, so there will be an opportunity for everybody to submit questions, and we'll get to as many as we can today while we're on the call. So next slide, please. Okay, a couple of housekeeping items. You are all muted right now, so you can't speak. We can't hear you. So if you'd like to ask a question, we welcome all questions. And there's a couple of different ways that you can send us messages. There is a Q&A box at the bottom of your screen, and you want to click on that Q&A box if you want to ask a question of the speakers. So click on that Q&A box at the bottom if you have a question for the speakers. If you're having a difficulty, a technical issue, you can't hear us, any kind of non-speaker question, go ahead and use that chat box at the bottom. Questions about slides should come into the chat box, and we'll get back to you as soon as possible. And while we're at that, I'm going to go ahead and just answer that question. Yes, we will have slides, and a recording of today's presentation is going to be available for download. All of our slides and webinars are available for download at our resource page, which is www.ehiedc.org/resources, and I encourage you to visit that page. Next slide. For those of you who are not familiar with the eHealth Initiative, we are a nonprofit organization coming up on our 20th anniversary. We primarily convene executives from across the spectrum of healthcare, every stakeholder group in healthcare, and we try to discuss, identify best practices in transforming the delivery of healthcare using tech and innovation. This is just a sampling of some of the groups that we work with. So as you can see, looking at the different logos up there, we have providers, we have payers, we have vendors, health information exchanges, labs, all sorts of groups are involved in our organization and in the research, education, advocacy we do. And we do that because we believe that healthcare and interoperability is a group of connected organizations. And you can't solve these issues with just a siloed approach and working or speaking with one group in the healthcare industry. We've got to bring everybody together to address these issues. Our current areas of focus, we do a lot of really exciting work with the executives that we work with. Value-based care is a huge issue we've been working on this year, looking at cost transparency and prior authorization. We have another large initiative looking at interoperability, particularly around FHIR and APIs, and we'll be coming out with some programming later this year, helping people understand FHIR. And then we have another large initiative focused on privacy and security and cybersecurity of medical devices, understanding HIPAA, understanding privacy as it applies to kind of health-ish or health-type data. Lots of work happening there. And then finally, we do a significant amount of work around analytics and social determinants of health, and that's what we're here to talk about today. And I want to refer you back again to our webpage, ehiedc.org, because we've done a lot of work over the last year looking at social determinants of health, particularly with LexisNexis as well. We came out with a report earlier this year, a set of ethical principles around social determinants of health, which is available on the webpage here. So if you go to ehiedc.org, you can access that report. And there was also a webinar previously looking at that. So I encourage everybody to look at that. There's also a report up there that we did recently, about a month ago, looking at SDOH and ICD-10 coding. And there's another of other resources up there around social determinants of health. So there's a whole page of reports and fact sheets and different references that you can find on the ehiedc.org webpage. So I encourage you to go there. The slides from today and the webinar from today will also be available there online. And we're going to continue to do this work and continue these webinars and reports and briefings up on Capitol Hill to really try to help people understand what this issue is all about and try to advance it. And finally, I want to really thank LexisNexis today and Lizzy and her group, who's been extremely generous. eHealth Initiative and Foundation is a very small nonprofit, and we wouldn't have the ability to convene all these folks from across different stakeholder groups without the generosity and support from organizations like LexisNexis and others, who really help underwrite our ability to convene and hold webinars and bring everybody together in a neutral way, which is really a wonderful thing to be able to say thank you for. So I do want to thank LexisNexis for doing that and providing us with that opportunity. And with that, I'm going to actually turn it over to Lizzy Feliciano, who's the VP of Marketing LexisNexis Healthcare. And I just want to preface this by saying Lizzy's really been at the forefront of this. We've been talking about this for, Lizzy, it seems like 2 years now, convening all these groups and talking about, everything from ethical principles to what's working and how it's working. And Lizzy's really, I think, an expert in this field now, and I'm so glad that we've got her today to address the group.
Thank you, Jen. Claudia, you can go ahead and move to the next slide. So LexisNexis Risk Solutions partnered with EHI over a year ago in an effort to drive greater awareness and, more importantly, understanding around the value that social determinants of health delivers to the industry in this value-based, patient-centric environment. While the topic of social determinants is definitely not a new one, it most certainly has garnered more attention over the past 2 years than I think many of us on this call could have anticipated. There's a need that we, I think, have all come to recognize to treat the person, not just the disease, and that's quite difficult to do when your lens is strictly clinical data. So that said, there's a fine line between the sake of data for just data and data for the sake of creating an improved healthcare experience. And in an ecosystem where information is plentiful and everything is served up in a portal or through an app, I think there's a natural struggle that has emerged between the validity, the value, and the utilization of yet another new source of information. Next slide, Claudia. It's estimated that social, environmental, and behavioral factors account for 60% of an individual's overall health status. So it's no surprise that we're seeing the topic covered on such a regular basis. I mean, there's no shortage of headlines, and some of the stories that you see listed here are aimed to support that value story and that value proposition of this data asset. Others are there to potentially cast some doubt on exactly what social determinants are and how they're utilized. But I think it's just mirroring the fact that it's a topic that can't be ignored. So much so that we're seeing very large and prominent organizations like Kaiser, United, MVP, and many others consciously develop programs and invest their resources to address social barriers that could potentially be keeping their members from realizing optimal outcomes. And one initiative in particular that I wanted to call out was the introduction of the Social Determinants Accelerator Act of 2019. Claudia, you could click over to the next slide, and you can build. This slide is just a really high-level summary of the bill, and you could easily find this online and get the detail. But in summary, it really just supports the integration and the utilization of socioeconomic data and analytics to build programs across state, local, and tribal governments in an effort to impact health outcomes and costs, and also realize a return on investment on those efforts. I think the introduction of the bill was a critical signal to the industry that the incorporation of these non-traditional data assets is something that needs to be considered and incorporated into care coordination efforts and care delivery models. I think it's important to see that in 2019 there's been significant momentum in large organizations and the government standing behind the value that this new data asset can deliver into to healthcare. Next slide. I also think it's interesting to see that patients, although they might not understand that they're referencing social determinants of health, are in fact saying that this type of information could be useful. And I say that because, they're indicating that they want more collaboration between healthcare organizations and the communities in which they live. So this is a PwC Health Research Institute consumer survey, and it illustrates this exact fact, where the majority of the participants were saying that it's important that hospitals, health plans, employers all have some level of partnership with their local community resources to help them improve their health. So addressing social determinants of health is a win-win for patients in healthcare, and I think one of the most exciting things about this is the fact that it does create that bridge between healthcare organizations, individual consumers, and community groups that otherwise may not have had such a strong reason to work together. Next slide. So with all of this in mind, earlier this year, our organization, LexisNexis, partnered up with HIEs as well as many, many other amazing organizations that you see listed here in a collaborative effort. And the reason we all came together was because we acknowledged that there's a very large elephant in the room, and that is the appropriate use of this data. This type of personal information needs to be treated with the same privacy and ethical consideration that we apply to personal health information. So as a result of this effort, we published the guidelines for the ethical uses of social determinants of health. And basically what we wanted to do as stakeholders is put a stake in the ground and state that social determinants should only be used for the 5 reasons that you see outlined here: care coordination, recognizing health and wellness risks, mapping community resources, service and impact assessment, and ultimately customizing health services. We agree that if utilized responsibly, that it can definitely have a positive impact on health outcomes, and that should be the ultimate focus of the use of that data. Next slide. So organizations should really start by looking for current, comprehensive, longitudinal data that can be consistently linked to the individual patient within their populations. And it also should be provided in a standardized format. Some data sources that we consider valuable here would be utilizing public records, some proprietary records that can provide that exact type of data. We recognize that not all data correlates to health outcomes, and I think that's an important part. Organizations will want to look for information that has already been validated against health outcomes, or be prepared to validate that information through their own internal analytics groups. We believe looking for these aspects in socioeconomic data will be the best position for organizations to achieve the best outcomes possible. Next slide. So over the past several years, we've seen an evolution of the definition of social determinants, as well as just the understanding of what types of data feed into this concept and this philosophy. The first phase focused solely on census data or census type data. And while there is some value there, it's dangerous to make an assumption on an individual based solely on their zip code. This is especially true, for example, in a neighborhood in an urban location where income levels might be low. There may be significant Section 8 housing units. However, there might be an individual who lives in a newly constructed development or townhome who has a vehicle, can access a Whole Foods store, they can buy produce, and avoid any sort of nutrient deficiency solely because potentially that zip code is categorized as being in the middle of a food desert. The second phase attempted to acquire patient-level data, and this was a huge step forward. However, the first or the initial companies that were evaluated or considered as part of this phase tended to be marketing companies and bureaus whose data was never really built for this use case. And the result was, yes, it provided insights on financial aspects, but largely these were data dumps of questionable use because they never truly were tested or validated to have direct correlation to health risk. And there was also issues with the match and the fill rates of that data. Next slide. So when you think about the types of data sources that you want to consider, they kind of fall into these buckets. And truthfully, there are 5 buckets. 4 are represented on this slide. And the 5th bucket, which we call access to care, is greatly represented by the individuals on this call, the providers, the health plans, et cetera. So we'll kind of focus on these 4. And when procuring non-clinical data, it's important to validate that the attributes you're looking at are filling these buckets. When we look at social and community context, you're really trying to understand how engaged is an individual in their community, how far removed are they from relatives or close associates. From a neighborhood and built environment perspective, is their neighborhood safe? Do they have access to walking trails? From education, are their family in their household educated? What's the level of healthcare literacy within that household? And of course, economic stability. Is there a trend of addressed instability or homelessness? Do they have the necessary income and financial assets to afford, adhering and following a care plan? Those are all critical to the overall health outcomes of an individual. Next slide. So delivering success, if you're looking at how to pull SDOH into your processes, requires first for everyone to sort of separate myths from truth. And some of those I'll talk about here. The first one is that socioeconomic data is just more noise in an already data overloaded world. The National Quality Forum, the CDC, the World Health Organization all have acknowledged the impact and the importance of addressing social determinants. In addition to being really valuable data, socioeconomic data can actually make patient risk assessment more efficient and less time consuming. For example, socioeconomic data can eliminate the need for many of the survey questions that we all have to fill out time and time again. The subsequent manual entries currently used, saving staff time, decreasing the risk of errors from manual entry. This data could be integrated into EHRs, population health systems and platforms for easy access when making decisions. For hospital health systems concerned about overwhelming physicians with data, other medical staff or social workers or even newly created positions like health coaches can help assist patients getting connected to the right resources. It's also important to understand that not all data on a person is a social determinant of health. For example, we've seen providers gravitate towards marketing data mainly because it's readily available. That type of data is readily there. However, marketing data was not designed for this purpose, right? It's designed for messaging during a campaign outreach, not to improve outcomes or target care interventions. Our data statisticians performed a comparison analysis and found that true socioeconomic data was as much as 17% more accurate in predicting health outcomes than marketing data alone. Clinically validating the attributes against actual outcomes is super important. And some of those attributes that you might validate, you'll find don't correlate strongly enough to be incorporated into your programs. For us here at LexisNexis, in an analysis of over 560 attributes by our data science team, we found that 442 were found to correlate strongly with health outcomes like readmission, medication adherence, hospitalization, and overall healthcare costs. Next slide. Here's an example that we were able to identify how close a patient's nearest relative or associate lives to them. And it was important because it provides insight into their social and community context. Our data scientists found that patients who have relatives or associates living less than 25 miles away were more likely to adhere to their medications. There's a drop-off when the nearest relative was more than 25 miles away. Now, knowing this, more education could be provided to the patient on their medications, or programs could be put in place to have those medications delivered to their homes on a regular basis to improve adherence. Next slide. Another example of the impact is related to economic stability. Our data scientists found a correlation between readmission to hospital within 30 days of an inpatient hospital stay and the sum of tax-assessed values for all the properties owned by that patient. The correlation showed that individuals of the same age who have higher average property values are less likely to be readmitted to the hospital within 30 days than those who have lower average property values. These are just two examples among hundreds of ways that socioeconomic data can provide important insights into any predictive modeling effort. Next slide. And Claudia, you can go ahead and build this out. 2 more clicks. So I thought it would be interesting, go back one. I thought it would be interesting to look at this through the lens of an ACO. We typically talk about socioeconomic data from the lens of the payer and the provider, but I think ACOs are in a position to utilize this data as well. Sources like Social Determinants of Health provides critical insights into the utilization and spending and even the risk of hospital readmissions that can impact Medicare reimbursement rates and even star ratings. SDOH can help ACOs prepare for important changes to quality programs like the CMS Quality Payment Program in 2019. Particularly, there's an increase in the weighting of the MIPS cost category from 15% up from 10%. ACOs can correlate spending trends with this data to more efficiently allocate resources and contain unnecessary spending. They can also correlate utilization data like emergency department visits and acute care hospital days per 1,000 with social determinants of health data to understand why certain patients might be accessing high-cost services and potentially steer those patients away to a lower cost setting. Next slide. And you could build this out as well. One more, perfect. And here are 3 quick examples that we could go through. So if we have an ACO that notices an uptick in spending for patients with heart disease, relatives, associates, and zip code data can help that ACO identify patients who may be socially isolated so it can proactively connect them with community resources to provide social support. An ACO might see an increase in emergency department visits for a diabetic patient, and income and education level information might help that ACO identify patients who would benefit from care coordinators to provide ongoing education on how to take their insulin properly. An ACO decides to target obesity in an effort to improve health outcomes. Understanding the income, the crime index, and the address data could help that ACO identify patients that would benefit from nutritional counseling and access to healthier food options. And finally, the next slide, kind of to summarize, if you have access to all of this data, what are the mechanisms through which you can integrate it into your existing operations? And these are 2 of the ways that we at LexisNexis see this happen most commonly. There's raw attributes for modeling and predictive risk scores for those of you who have built analytic shops. And there's also risk scores that are for use more directly through care management platforms. Data science teams can identify data that is relevant by clinically validating the attributes against healthcare outcomes, and this information could be used solely on its own or in conjunction with claims data. The attributes can be used within existing models or to help build out your predictive modeling efforts. And then the second way of utilizing the social determinants of health data is through predictive scores. And these health risk prediction scores are provided at a patient level, and they leverage validated socio data and help provide a full picture of the future risk that any individual might pose and help your organization align the appropriate resources for that individual. And with that, I will now turn it over to our next presenter, Jordan Luke from CMS.
Good afternoon, everyone, and good morning to those on the West Coast. I want to thank eHealth Initiatives and Foundation for the opportunity to chat with each of you today. My goal in today's presentation is to familiarize you with some initiatives taking place at CMS. I will say that not all the individuals engaged in these areas are on the call, so if you have questions at the end and I'm not able to answer, I do have a mailbox at the end of my presentation where you can submit additional questions. Next slide, please. So one common question I generally get is, what do we do at CMS Office of Minority Health? And the truth is we wear many hats, as I imagine many of you do in your role. But our team primarily focuses on reducing disparities for racial and ethnic minorities, rural populations, people with disabilities, and sexual and gender minorities, so LGBTQ. Our vision is to ensure that all beneficiaries are able to achieve their highest level of health, and we work across the agency to make sure that equity is embedded into the policies and programs of the agency. Next slide, please. So I'd like to start off by just clarifying when I say disparities, what we mean. There are some definitions out there, but I want to just clarify what I'm talking about when I say that. So for us, disparities are potentially avoidable differences in health between groups of people who are more or less advantaged socially, as shown in this figure. And so what you'll see is that not all differences are necessarily disparities, and our office really focuses on the areas where there are avoidable differences in outcomes. Next slide, please. And so how do we approach this work? So there's three domains of our work in the CMS Office of Minority Health. First, we focus on increasing understanding and awareness of disparities. So we try to leverage existing information and data that we have to uncover where disparities are greatest for different populations. And then with that information, we develop and disseminate solutions to support you all and all the different stakeholders we work with at CMS so that we can then implement sustainable action. Next slide, please. But today I want to focus on the social determinants of health, since that's a big focus area right now for many of us. And you might have seen this framework before, but there are many types of social determinants of health, and you're likely already looking at these issues. But there are 5 domains that the social determinants likely fit into. And the truth is that there are many ways to collect this information that are already taking place. So today I'm going to focus on 3 ways that some healthcare organizations are currently collecting social determinants based on the research we've done and also some initiatives we have at CMS. As you might imagine, this is not a comprehensive list because there are other areas where this data is being collected, but I'm going to focus on these 3 areas, and then I'll wrap up with a couple of resources we have developed for the public. Next slide. So many of you are probably familiar with Z codes, but I'm briefly going to touch on this area. So Z codes, when ICD-10 was implemented, there was a subset of ICD-10 codes called Z codes, and within the Z codes there are a subset of items that can assist organizations with collecting social determinants of health. You can go to the next slide, because I actually listed the ones that focus on social determinants of health. And so one area where we're finding that many folks haven't heard of this guidance update is historically only providers could collect ICD-10 codes, but last year the ICD-10 Coordination Center, which the American Hospital Association is a part of, determined that other members of the care team are able to collect Z codes on social determinants. And so as we think about trying to reduce burden for providers, this new guidance has opened the door for that to be a possibility. So for example, let's say a social worker could identify if an individual is facing housing insecurity, food insecurity, social isolation, and that information can be used in the record. Next slide. So another initiative we have at CMS, and I won't spend a whole lot of time, this has been out a few years, but it's the Accountable Health Communities model, which came out of the Centers for Medicare and Medicaid Innovation. And basically this model developed a screening tool to identify social determinants of health and work with our model participants to refer and connect individuals to social service programs and community resources that meet the needs that were identified. You can read more about this on the CMS website, and the goal is to look at how that referral, the identification and referral process leads to changes in health outcomes. Next slide. But in doing this work, one common thing we've heard from the public is there's a lot of social determinants of health out there, and there are many different frameworks, and so there isn't yet an agreement on which areas organizations should focus on. So a big part of what we do as an office is engage with the public, with you all, to learn about areas that you're prioritizing and challenges you're facing so that we can collaborate and work on this together. So I wanted to highlight the 6 different domains, and you can also click over to the next slide. And as you see here, there's the first domain is from the Accountable Health Communities, the National Academy of Medicine, Healthy People 2020, ICD-10, the Prepare tool, Health Leads, and there's probably more. But these are some examples of different indicators related to social determinants of health. So the most interesting thing I think I wanted to share with you, next slide please, is some rules that were recently finalized in post-acute care related to social determinants of health. Some of you may have read the Impact Act of 2014, which requires CMS to collect data elements in prospective payment systems. So we embedded social determinants of health into the patient assessment forms based on feedback we heard from different stakeholder organizations, which part of that listening elevated 5 areas that the stakeholders thought we should prioritize. First, they provided feedback on the social determinants that they felt should be included in the assessment, and we also heard that it's important to have flexibility for tools to meet local needs, and also allow patients to self-identify. So a provider, for example, shouldn't be assuming what the patient's response is on any of these questions, and to think beyond just the medical care, so the 4 walls of the office, and then to also think about providing best practices for question design. So after we went through that process, next slide please, we then began working with different stakeholders within CMS to propose and finalize new data elements in the post-acute care setting that I'll talk about more in a minute. But we anticipate that this proposed new category of social determinants of health will inform provider understanding of individual patient risk factors and treatment preferences. We hope it will facilitate coordinated care and care planning and improve patient outcomes. We propose to deem this category necessary and appropriate because using common standards and definitions, especially in the post-acute care setting, is important in ensuring interoperability exchange of longitudinal information between post-acute care providers and other providers as well. Collecting the data as proposed will provide the basis for some of our periodic analysis on the relationship between individual health status and other factors, and quality and resource use and other measures, which is required by Section 2D2 of the Impact Act, and to assess appropriate adjustments accordingly. So we can go to the next slide, which will call out the 4 areas where this rule was finalized. So the first one was in patient rehabilitation facilities, skilled nursing facility, long-term care hospital, and home health. The 5 areas that were finalized, and actually some of these were already in the patient assessment, so part of our work was focused on aligning the areas being asked. So the first was race and ethnicity, second, preferred language interpreter services, health literacy, transportation, and social isolation, which were all areas that that during our listening sessions, stakeholders highlighted as the most important ones for CMS to prioritize. And so on the next slide, I highlighted where the questions came from. The questions in the patient assessment form are already widely used on other assessment forms out there. So if you want to look more into that, at the end of the slide in the appendix, I included the actual question in there. You can read more about the proposal, the final rule in the Federal Register. So with that, I'm going to start to wrap up, but I just want to highlight a couple of resources that we've developed, because obviously just identifying social risk factors doesn't necessarily lead to action, and we realize that there's more resources needed to understand what to do with quality issues that are identified through these efforts. And so a couple of resources we've developed include a guide on developing a language access plan, which is developed through listening sessions we held with leading experts on language services. And it provides best practices on how to do a needs assessment, offer language services, provide language notices, train the workforce, and also evaluate. And then the second product is called Lessons from the Field, which really highlights, they're like mini case studies of organizations that are already doing this work and how they're doing it. And then the other item, which ties to the health literacy question in the post-acute care setting, is From Coverage to Care, which, as many of you might have heard from your family members, they might not understand the coverage that they have. And so we developed this product to level set and explain exactly how each individual can take advantage of the coverage that they have, because just because someone has coverage doesn't mean they necessarily understand how to navigate health care. And so this resource was developed in plain English for beneficiaries to take full advantage of their benefits. And there's an email box at the bottom if you'd like to request any of these resources. And then the last thing I'll mention is we believe it's important to acknowledge organizations that are leading in this space. So a few weeks ago, we did a call for nominations for a CMS Health Equity Award, and we are accepting nominations up until the 15th of November. And if you want to learn more about the award, you can visit the CMS Office of Minority Health website, and the form to apply is on there. But I gave an example here of one of our past awardees and really how they're using this information to improve access and quality for those that are most vulnerable within their population. And if you have any questions, feel free to reach out to us. We offer health equity technical assistance. If there's any projects that you're working on and you need support, we believe in collaboration, and we can connect you to different experts that are working on those issues. And so I have the mailbox there for any of you that may have any follow-up questions. And so with that, I'll go ahead and wrap up and turn it over to the next speaker.
Thank you so much, Jordan. And we're going to have all these slides, and Jordan actually has a few extras as well that we'll distribute online. So Chris, you ready?
Yes, thank you so much. Thank you, everyone, for coming to our presentation this afternoon. Thank you to EHI, and thank you to my fellow presenters. I'm going to discuss the implications of understanding social determinants of health from the perspective of running a health information exchange. This will hopefully draw some of the themes we've already discussed, and also perhaps get a little closer to nitty-gritty actually trying to make this work in a real solution. So next slide, please. So I'd like to cover off in my presentation just a few points. Privacy and security of sensitive data and patient consent, relevant data, where we get the data from, normalizing, standardizing. Combining the clinical and social determinants data is a best practice, and in providing and presenting information back, especially to providers and so on, it's often that you need both the clinical and the SDOH if you're really going to understand the patient. Look at FHIR and data governance, and then we'll go back to questions. Next slide, please. So I thought one way to lay this out is to look at the challenges that we've seen and that are potential roadblocks or things that need to be overcome in order to incorporate SDOH in your health information exchange. The first comment is that although this is a new domain, we're not hopeless. We have dealt with integrating data, clinical data, for a long time, and we do know quite a lot about it. Privacy in relationship to sensitive data, there's lots of different aspects to this, but traditionally we can take something like a sexually transmitted disease test and say, well, that's sensitive, so only particular people can see it. When we translate that to social determinants, it's quite hard to know whether you should be broadcasting this widely to all users of your health information exchange or whether you should keep it quiet and only available to certain people. And I don't know the answer to that yet, but that's still a challenge. We have to be very careful. One of the categories of data that we can handle in this way is the patient's financial data. I think Lizzy said, some of the patient's financial data correlates with health matters. Now, the problem is there are at least some legal requirements around that, and loosely, you're not allowed to use the social data to issue loans to people, as we're not a financial institution, but we need to steer clear of that. The clinicians versus the data brokers. So do we want providers to capture this data? And clinicians say they do, they want it, and clinicians say they're willing to capture it, but in reality, if it takes a lot of time and effort, then maybe it's not so easy. Once we've captured the data, we want to integrate it. And I think integration is still, interoperability is a challenge with clinical data. And so I'll try and show you some things as to where that issues arise with the social data. And really understanding it. So from a health informatics perspective, understanding the data and in terms of its meaning. Next slide, please. So there are a multitude of social determinants assessment tools and terminologies out there. And I think we shouldn't ignore, for instance, the legacy. So, this is not happening in a vacuum. As a medical student, I was taught to take a social history. Probably wasn't a greatly detailed one, but even in recent times, we ask care coordinators, and when people turn up to hospital and do these initial assessments, we often include a lot of social data in those initial assessments today. The challenge is, of course, those assessments are the data is largely buried and hard to find. So the agreed standards for data exchange, and we'll talk about that in a minute, and the worry that we may swamp clinicians with too much data, and Lizzy mentioned that one as well. The other issue that I have unfortunately come across from time to time, and I think CMS and others are definitely helping, but you do get this, well, prove to me that this data actually saves someone some money, or prove to me that there really is a business case for working on this data. And so long as we're living in a value-based care and population health world, then it's easy to say, well, there will be funding for this because you'll save some money and everything will be better. But it's not necessarily a straightforward business case. So let's leave it at that point. Next slide, please. So identifying those challenges, what can we do if we run our HIE to address them? One of the things is the consent register. So wherever the patient's seen, we need to know whether or not they've consented to the sharing of this information. Some situations you may have to ask consent again, sometimes not. In some situations we're finding with consent that it's getting more fragmented and patients are being asked to consent to more different things, which is a challenge of itself. We've always provided role-based access controls for clinicians to look at the data. I don't think we right today understand exactly how those roles would work, although presumably clinicians can access data and non-clinicians cannot. Technically, we're needing to get to attribute-based access control. So every item of data, at least in theory, has the potential to have an access control applied to it. Now, Jordan's talked about the ICD-10 codes, and I'll just, on the next slide when we get to it, I'll explain a little bit more about why that's a challenge for HIEs. As we move forward, every use case that we bring forward, so everyone, we've been talking about the value of this in care coordination and care transition management. When the patient goes to the community, it's helpful to know if they're going into a good situation or a difficult situation where they're not going to be able to cope. Some other ones that I've come across, you know, the high-risk pregnancy. So intuitively, having social determinants data should improve our ability to predict if a pregnancy is going to be high risk and help us to adjust to that. And I think we should absolutely explore that, but we don't have the clinical equivalent of a randomized double-blind trial. So just something to bear in mind. And I'll be talking about FHIR some more in some more slides. Next slide, please. So as we dig into the ICD-10 Z codes, and we saw there are a large number of Z codes, and if depending on resources, but United Healthcare has an excellent website page where they list how the ICD-10 codes that they would like people to use and the different elements that they reflect. Just to show you that it's not a static thing, I think it's CDC suggested that there should be much more fine-grained ICD-10 codes. So C59.61, unable to pay for prescriptions, .62, unable to pay for utilities, and .63, unable to pay for medical care. Those are proposed, and so we still have to get clinician acceptance for that. Obviously, being more fine-grained would be great. But let's look also, there's link codes. So the link code 76513-1, how hard is it for you to pay for very basics like food, housing, medical care, and heating? It sounds to me like almost exactly the same thing, but these are kind of informatics understanding that we're going to need to get more sophisticated at. And then SNOMED has codes for being financially poor and for being borderline poverty. From a health information exchange perspective, what we've done in the past where we get similar data from multiple sources is we normalize, standardize, and map it. At this point today, I couldn't pretend that we can do that with this data, but it's a good challenge. Next slide, please. As we were working with EHI on the ethical use of social determinants data, one of our participants from Kaiser Permanente introduced us to the Gravity project. And although this is early days, I think it's a nice project to be aware of. And again, I think what it does is by working in the context of FHIR, we know that FHIR works well for health data. So we can take some of those same tools, apply it to social determinants, and see if that helps us get to, you know, a well-interoperable situation. So as a group, the Gravity project is working, you can see there, develop semantically consistent FHIR profiles, resources, and guides. Ensure that we're using the right terminology, and vet the information structures, collaborate with industry to test, run the APIs that evolve, and to conduct research on the efficacy of their use. So I really like this project. It's still early days, but it seems to be doing the right things in terms of and taking the knowledge that we've got from interoperability on clinical data and applying it to social determinants data. I think it's very exciting and may help us to actually move forward more quickly than we otherwise would. Next slide, please. And it's been stated by the others as well, but we do need to be very careful about the governance of this data. One of the from an ethical perspective, one of the worst things would be if this data could be used to deny care. So we need to be careful, because if someone learns that this patient is in poverty and can't afford to pay, we can't let that be a barrier to them accessing care. But in addition, the data, I think some of it is undoubtedly sensitive, some more so and some less so. It's important that we use our existing data governance mechanisms, which we should have in almost every HIE has a data governance mechanism, and looking at this from that perspective. So agreeing on the consent process, who will collect the data, where does it originate, how will it be handled, what is the data dictionary, any data that we capture, is it valuable, what are the access controls, and so on. And the last point there is highly important. And if we're going to use the data for care coordination, that's one thing. If we're going to use the data to predict that a given person is going to have trouble in the future, it raises all sorts of ethical concerns, in the sense that we need to be 110% certain that the algorithms are predicting accurately for the future if clinicians are going to rely on them. All these kinds of concerns, it's both data governance and clinical governance. So as well as the data people and privacy people, I think it's really important that clinicians are able to oversee the data that's going into the health information exchange, make sure it's used properly. I think that's my last slide.
Great. Thank you so much, Chris. All right. Well, we've gotten, first of all, thank you to all of our speakers. I think we've heard a really nice overview this morning, if you're on the West Coast, about social determinants of health and some different efforts going on out there, a nice broad spectrum here. I want to take us back to the beginning, Lizzy. I know you had mentioned the ethical guidelines that were developed earlier this year, and we had a question about predictive modeling and, using SDOH data for that. Could you talk a little bit about how that fits in with the ethical guidelines?
Sure. So I think the key thing to emphasize is that the ethical guidelines refer to the use very specifically of that data, whether it's being built or added as raw attributes into a predictive model or used as a score. So at the end of both of those options, the key is that it is for the purpose of care management and personalized care. If the predictive modeling effort is in fact to help stratify a population for the purpose of improving care coordination, care management, and allocating resources to help that individual, then yes, that aligns with those ethical guidelines.
Yeah. And if people are looking for more information, I believe Emma is going to tweet out a link to the ethical guidelines online through the chat. So that'll be available for everybody as well. Jordan, so we've had a number of questions about CMS and how they're reimbursing providers for SDOH. Could you talk a little bit about that? And then specifically to the Z codes as well. How's that going to impact some of the county benchmarks that payers are using?
So that's a great question to submit to the mailbox, because the payment folks aren't here on the call. But okay. I don't think in Medicare that the Z codes are reimbursed, is my understanding. But feel free to submit those questions to the Health Equity TA mailbox, and we'll make sure to get that to the right people and get you a response.
But there is hopefully a determinant, in the future where CMS is thinking to reimburse providers in some way. I mean, aren't we kind of looking to that direction, hopefully?
I don't have the folks present here for that, so I don't want to speak on their behalf. Yeah, but I'm sure that there is some guidance we can provide on that. So feel free to submit those questions, and we'll connect you.
Great, thank you, Chris. So can you talk a little bit about? Oh, go ahead, Chris.
No.
So we have some questions about what are some good sources for finding clinical evidence or studies on social determinants of health and how it works with treatments and outcomes. And any thoughts on that? Or Lizzy, if you want to jump in on that either also?
I can perhaps, we can tweet out some links related to that. It can be, it's definitely emerging. You can still look in the standard, one way of getting at this is the standard clinical literature, the PubMed, the research, the NIH, which obviously better places to get high value, highly peer-reviewed kind of work. The problem is that there's not a lot, in my understanding. So, for instance, to give you a concrete example, we were interested in whether social determinants of health could be an indicator that a person might be involved in the opioid crisis or substance use disorder. And I researched that as hard as I could, and in the end, I really couldn't find really clear answers. So it's new and emerging. I do have some links I'll put together and supply to the group.
Okay, great.
Lizzy?
Yeah, I would agree. I mean, we are we work closely with our customers, our clients, our payers, and outside of some of the resources that Chris just mentioned, you would be hard pressed to find a plethora of resources currently. But we hope that changes as we see more adoption in the coming months and years.
Great. And I know, Jordan, you shared some examples of SDOH models, and it sounds like there's a place for that on the CMS website as well.
Yeah, so the end of the presentation has the different questions that we've added to post-acute care, and then you can also read more about the Z codes on the ICD-10 guidelines that CMS releases, and then there's also information on the CMS website related to the accountable health communities.
Okay.
Just to comment, there is out there you can find many examples where they talk about social determinants of health being 30% of an outcome or 80% of health outcomes. You can certainly find examples where people have analysed and tried to validate that. It seems that it is clear that social determinants are significantly more important in their impact on health than actual clinical care. But in terms of research, once you get past that, you kind of get in a bit of a swamp, and it's not clear exactly how fixing one necessarily makes a difference. Just to give you an example, and I'll see if I can track it down again. If you're interested in sort of comparative health policy, then you know that the US spends a significant amount of money more on healthcare, but gets significantly worse outcome than other countries. And one explanation for that that's popular is, oh, well, the US spends the money on healthcare but not on social services, and say that the UK spends it on social services, that saves money. But I had a study the other day and it completely blew that away. So it's definitely an evolving area and no glib answers.
Yeah, and that's one of the areas that I wanted to draw attention to when describing the Impact Act, because that's part of what HHS was tasked with researching, is how those social determinants are impacting health outcomes. And one of the challenges is the lack of data to assess that impact. And so I think with some of these new initiatives that are taking place, being able to better quantify and respond to those issues will probably be soon on the horizon.
And Chris, I know the Gravity project is in early days now, but you did get a question about HIEs that are involved in the Gravity project or piloting the Gravity project. I don't think they're pilots yet.
No, not that I know of.
But are there any HIEs that are involved in that project?
Again, not that I know of. That I don't know.
Okay.
Yeah, not enough. Yeah.
Okay.
We'd be happy to get an answer for people on that one though, because it does matter. Yeah. I mean, the FHIR APIs, just the FHIR APIs, they are certainly emerging and in clinical use cases. So everybody's got something that they're playing with the FHIR APIs, but on the social side and Gravity, I'm not aware.
Okay. There was also a quick question about a study that you guys just mentioned on social services. Could you mention that again? Jordan, I don't know if that was you.
No, I don't think that was me. I think that was.
There was a study which debunked that it was a study that debunked the concept that the reason healthcare is expensive in America compared to the UK, for instance, is because of less spending on social services. I will try and find that study. It's definitely interesting, but yeah.
Okay. And another person is telling me to look at the health affairs study. So
yeah, that'll be it. It will be health affairs. Yeah.
Take a look at that. Okay. Unfortunately, we're at the top of the hour, actually a minute or two after the top of the hour. So we do have a few more questions here. But what I'm going to do is I'm going to give these to the speakers and so that they can get back to people if they feel they can answer them. And I do want to thank all three of our speakers this afternoon for really, really wonderful presentations and everyone for their thoughtful questions today. As I mentioned earlier, this is a really important topic, and we're going to continue to hold these webinars and continue these discussions over the coming weeks and months. So this isn't the last that you've heard from this group. So thank you, everyone, for joining us today, and thank you to LexisNexis again for supporting the webinar today. Everyone have a wonderful afternoon.
Thank you so much.
Thank you.
Thank you. Thanks.